caloric test in vestibular migraine patients, they are highly empty. This is one feature that differentiates. So this is one chart in the interictal phase. There is a reduced response on the right side. So next one, in the interictal phase, the head impulse test is normal. That is, VOR is usually normal. The gain is usually normal. But whereas in some cases during the ictal phase, if you check the head impulse test, the gain is reduced. So again, fluctuating head impulse test. So fluctuating caloric test, fluctuating head impulse test. And also in postography during interictal phase, there will be normal results will be there, but there will be excessive visual dependence can be there. And of course in pursuit, you can have a saccadic pursuit, particularly in the vertical eye movement. So like this pattern you can notice in the pursuit. And there will be a more than 2-degree deviation in the subjective visual vertical, which was noticed in most of the patients because of the disruption of the otolith and the semicircular canal pathways. So you can find lots of variants of nystagmus in the interictal phase. You can find a spontaneous nystagmus. Usually these patients initially present with spontaneous, later goes into positional nystagmus. So you can find central positioning nystagmus, you can find gaze evoked nystagmus, you can find head shaking nystagmus or vibration induced nystagmus. So this is a gaze evoked nystagmus on right and left, parallelly I have kept. And head shaking nystagmus. Dr. Prateek has given that classification which has been accepted at the VAI, and also he has presented that at Burmese Society, last Burmese Society meeting. Type 2B. Type 2B high frequency head shake nystagmus is one feature of vestibular migraine. I will show it, time permits for me. Just I'm skipping these things. And during the interictal phase, you can find sensory neural hearing loss. A mild bilateral sensory neural hearing loss with downsloping pattern, particularly at the high frequencies. This is one of the most common features what we see in vestibular migraine, which differentiates it from even from Meniere's disease, where you have a low and mid frequency loss, particularly unilateral. And sudden sensory neural hearing loss. The patient comes with sudden sensory neural hearing loss. Any patient of sudden sensory neural hearing loss should be offered a trial of migraine preventive therapy along with your steroid. Please consider migraine as one of your differential diagnosis or cause for the sudden sensory neural hearing loss. And also unilateral tinnitus, sudden onset of tinnitus. Consider migraine as one of the differential diagnoses. So in the ictal phase, that is during the attack, what are the findings that we can have? We can have different patterns of nystagmus. Here, as I have told, the head impulse test will be affected. The gain will be reduced. Whereas in an interictal phase, the head impulse test is normal. So that means in the previous consultation, you are having a reduced VOR, VOR is normal, and in this consultation, the VOR gain is reduced. In the earlier consultation, the caloric response is reduced. In this consultation, in this visit, the caloric response is normal. Again, that means the caloric and the VOR mismatch is again present. So that is actually maintained, which is also seen in Meniere's disease. And in clinic also you can check the smooth pursuit. It's not going very smoothly. It's like taking a break, like a jerk. It's like what we call it a saccadic pursuit, both in horizontal as well as in the vertical direction. So just I'll move quickly, and this is the pattern what we see on the graph, saccadic pursuit. So during the ictal phase also you can see a head shaking nystagmus and normal calorics. Head shake nystagmus. Prateek, you will be telling about this in future in your next slides. No? So this is the biphasic nystagmus, what you see in vestibular migraine. This is a classification that has been given by Dr. Prateek Porwal at Burmese Society. So this could be either due to uncompensated unilateral vestibular lesion or due to vestibular migraine. We call it as 2B high frequency head shake test nystagmus. Just I'll be skipping this thing, but I have to give this due credit to Dr. Prateek, who has seen more than few thousands of video nystagmographies. And after seeing so many video nystagmography reports, he has come to a logical conclusion that even in migraine, there is, you can see a high frequency head shake nystagmus. The specific pattern that is labeled as 2B, which has been acknowledged and appreciated by all the big guns of neurology and neurotology at Berlin. Great, Prateek. So just I'll skip this thing and go. So coming on to the great mimics of vestibular migraine very quickly. First thing is BPPV, because these patients initially start with spontaneous vertigo, then complaints of gradually progress to positional vertigo. Whenever I am lying down, I am getting vertigo. So obviously BPPV is your primary consideration. So when BPPV is clinically diagnosed based upon the history, but does not have a classical nystagmus pattern, either does not fit into posterior canal, horizontal canal, or anterior canal in positional testing, and not responding to your maneuvers, consider vestibular migraine. 38% of the patients complain oral symptoms like fullness, tinnitus, subject to hearing loss. Most vestibular migraine patients complain these symptoms bilaterally. Most of them complain bilaterally. If they complain bilateral, no issues with Meniere's. But if they complain of unilateral, then comes the problem. Although 1/3 of these patients may experience these symptoms unilaterally, it is with these 1/3 of those patients where we face the difficulty of either it is Meniere's disease or vestibular migraine. So these are the great mimics of the vestibular migraine: triple PD, BPPV, post-concussion syndrome, Meniere's disease, stroke TIA, and episodic ataxia type 2. There are few slides where comparing the symptoms together and opposite symptoms in each disease that were there. I can go ahead, I will go ahead. So you know what is triple PD. What are the features that are common in triple PD and vestibular migraine? Both may be triggered or exaggerated by a passive motion, visual stimuli, or complex visual cues. In both the things it can happen. Anxiety symptoms also may coexist in vestibular migraine. Both vestibular migraine and triple PD can coexist in a single patient also. So treat both the disorders with SNRIs like venlafaxine or duloxetine. If both the things are there together, this is the treatment: venlafaxine or duloxetine. What are the features that differentiate vestibular migraine and triple PD? Vestibular migraine is episodic. It lasts for 5 minutes to 72 hours. But whereas triple PD continues more than that, for few days, few months. Symptoms that are present more often than not and vary throughout the day, and which are worsened towards the end of the day. By end of the day, the symptoms get worsened. It is suggestive of triple PD. So migraine specific associations like headache, migraine triggers like barometric changes, menstruation, specific changes in vestibular migraine. Coming on to BPPV, we all know what is BPPV. It's a positional nystagmus, and the nystagmus lasts less than 1 minute in canal lithiasis and more than 1 minute in cuprolithiasis. We can see a classical crescendo-decrescendo pattern in canal lithiasis. This all basic stuff we know. Now, what are the common features between vestibular migraine and BPPV? Both may present with positional episodic vertigo. Both may present with ongoing vertigo in certain positions, that is cuprolithiasis of BPPV and vestibular migraine can last for more than 1 minute. If it is less than for 1 minute, that's okay. But if it is for more than 1 minute, either your diagnosis is vestibular migraine or cuprolithiasis. Both may present with geotropic or apogeotropic variants. particularly in the ictal phase. In the ictal phase of vestibular migraine, you can have these geotropic or apogeotropic variants of nystagmus. Sometimes, of course, the worst scenario is both may coexist. What are the differentiating features? In BPPV, you can find a classical crescendo-decrescendo pattern of nystagmus. Usually, BPPV is not associated with any of the neurological symptoms and typically triggered only by active motion. You will not have any passive symptoms. Of course, next is the post-concussion syndrome. This occurs usually after trauma, associated with headache, photophobia, phonophobia, visual focusing issues, and fatigue. It may be also associated with the convergence insufficiency. See, the one test that you need to do in post-concussion syndrome is the convergence. So, what are the common features between post-concussion syndrome and vestibular migraine? Symptoms of headache, photophobia, phonophobia, visual complaints, and fatigue. Differentiating between them is slightly difficult, except that there is a history of trauma. So you can try to treat them with any tricyclic antidepressants or gabapentin. What are the differentiating features? In post-concussion syndrome, typically tends to improve slowly with some fluctuations after the event, after the injury. Avoid topiramate in such kind of patients. If topiramate is your drug of choice for vestibular migraine, kindly, and there is a history of trauma for the patient, kindly avoid topiramate. And also avoid propranolol as migraine preventive in patients with significant fatigue due to post-concussion syndrome. So avoid topiramate and avoid propranolol. Probably you can move with clonazepam. In these patients, migraine with a history of concussion, where you are doubtful whether it is just migraine or post-concussion syndrome. Coming on to the great mimic, the Meniere's disease, I will not go in detail about this because next half an hour will be about Meniere's disease and vestibular migraine overlap syndrome. Both may be associated with unilateral vestibulopathy, may be associated with all the symptoms. So these are the differentiating features. So most of us ask, when there is a overlap between Meniere's disease and vestibular migraine, what is the drug of choice? Is flunarizine, acetazolamide, beta-histine? In my experience, and of course in literature, and according to most of the neurophysicians across the globe, verapamil is the drug of choice. Verapamil works much better than all these traditional drugs. Bilateral rather than unilateral manifestation of endolymphatic hydrops and MRI, mild hydrop grades and preferential involvement of vestibular, than cochlea favors vestibular migraine. If you take MRIs, this is a classic thing, not what you can see. There will be bilateral enlargement of the, there is a bilateral enlargement of the endolymphatic hydrops. Bilateral endolymphatic hydrops will be there in vestibular migraine, whereas it will be unilateral in Meniere's disease. So this is one differentiating feature. That means the take-home point is, even in vestibular migraine, we will be having endolymphatic hydrops. Presence of endolymphatic hydrops does not give you the diagnosis of Meniere's disease. And preferential involvement of vestibulum than cochlea, only vestibule rather than cochlea, that means more dilatation in the vestibular part and no dilatation seen in the cochlear part. Again, your diagnosis is vestibular migraine rather than Meniere's disease. Coming on to stroke and TIA, I'm just moving out all these things. Now, what are the common features? Migraine may be associated with neurological symptoms, like in complex migraine, you can be having more complex, more neurological symptoms will be there. You can also have hemiplegia or even aphasia in a complex migraine patients. But in complex migraine, your MRI will be normal, whereas in your stroke, the MRI can have the findings. One common and last finding, not so common, episodic ataxia type 2. But the differentiating feature is the age of onset. Usually episodic ataxia type 2 will start anywhere between 2 years to 20 years. So onset of the disease after 20 years is very rare. And we know that this is a calcium channelopathy predominantly in the chromosome, from the chromosome 19. So any mutation in the calcium channel, CACNA, calcium channel, 1A on the 19th chromosome, you can do a genetic testing. And one more interesting thing here is its response with estezolamide. The features are fitting with vestibular migraine, but not responding with your traditional migrainous drugs like propranolol or flunarizine, topiramate. Then you can think about episodic ataxia and go with estezolamide and 3,4-diaminopyridine. So quickly, treatment strategy. The main goal is to reduce the severity. There are two types of treatment: acute treatment and preventive treatments. This is for the ENT crowd. The most common treatment strategy what I offer for my patients is the lifestyle modification. Rather than the drug, this is the most important thing. Avoid triggers. Regular routine for hydration, eating, stress, sleep are beneficial. Treat anxiety, depression, pain syndromes, fibromyalgia and sleep apnea. So coming on to the general drugs that can alleviate the symptoms in migraine, vestibular migraine. One is the riboflavin, the other one is the coenzyme Q10 and magnesium, particularly either in the bisglycinate salt form or threonate salt form. And coming on to the nausea management, ondansetron or prochlorperazine. So menstrual migraine management with oral contraceptives. Avoid in some patients because there is chances of stroke in few patients, so avoid that. And aerobic exercising. Aerobic exercising is one important suggestion you have to give for all your migrainous patients, vestibular migraine patients. So this is the treatment summary from the. For acute episodes, you can use dimenhydrinate or sumatriptan. For prophylaxis, you can use metoprolol, propranolol, topiramate, flunarizine, valproic acid, amitriptyline, and estezolamide. Each drug has its own merits and side effects, contraindications. So you need to look the drug separately. So each one has been described independently, but so these are the treatment options that are available for the acute treatments: acetaminophen, NSAIDs, combination analgesics, ergotamines, migraine-specific preparations, melatonin or antiemetics. We know about acetaminophen. Just I am moving forward. NSAIDs also we know. We use naproxen, ibuprofen, aspirin, and even you can go with melatonin, which is important in regulation of the circadian rhythm. But avoid in breastfeeding and pregnancy, because most of the questions we have been asked, particularly the ENT crowd asks us is drug indications and contraindications, whether you can give it in pregnancy, in breastfeeding or not. So we have made a slides for each of the drug. So next is the migraine-specific preparations. We have three types of migraine-specific preparations. We call them as triptans, ditans, and gepants. So triptan is all the triptans we know is sumatriptan. Sumatriptan is well-known drug. And ditans and gepants. These ditans are 5-HT1F agonists, and the gepants are the CGRP antagonists. And also, of late I have been seeing many cases responding for, who are not responding for even for CGRP antagonists, they are responding for botulinum toxin. So there are 3 neurologists who are getting Botox injection from me. Of course, 2 of them are my classmates and 1 is a senior there. So coming on to the triptans, these are the triptans we know: sumatriptan, zolmitriptan, almotriptan. These are the ditans, lasmil, ditan, and these are the gepants. These are the gepants are the CGRP antagonists. Ubrogepant and rimigepant you can use. I don't know whether zavegepant has, with the intranasal form, has been in the market or not in India. I don't know. Neurologists should guide us regarding this thing. But this point I took it from Michael von Breven paper. So preventive treatment: beta blockers, anticonvulsant, tricyclic antidepressant, calcium channel modulators, and CGRP monoclonal antibodies. So European Association Headache Federation is currently recommending CGRP monoclonal antibodies as the first line option for migraine prevention. For migraine prophylaxis, European Headache Society has recommended CGRP monoclonal antibodies as the first line. So, etosipan and rimizipan. And of course, neuromodulation do have a role, but I don't have enough experience in this. And of course, most of you might be giving Botox for vestibular migraine. Earlier, I used to give to the patient in a supine position. Now, we are doing it in a sitting position only in a preempt protocol. This video again is almost like 14 minutes video, so just I'm forwarding. You'll be giving in different locations. You'll be targeting different muscles around the forehead. So most important thing is, again, after lifestyle modification, the most important thing is the diet. Try to avoid Ajinomoto or the tasting salt. You have to avoid. And also, so this is the diet chart what we give for the patient, recommended migraine diet chart. Avoid or acceptable foods. Avoid caffeine, chocolate, dry fruits. Dr. Srinivas has told, even after taking almonds or dry fruit, the patient is experiencing migraine episodes. And fermented alcohol like wine and beer. And most cheese you have to avoid. And in India, there are many cases who complain of migraine even after taking ghee. So you need to be more skeptical when you deal with the foods that are more rich in ghee. And fresh bread, yeast extracts, aged or canned foods, processed meats, all these should be avoided. What are the options that are available? That are on the right side. So, I'm a little late for 10 minutes, Prateek, but I try to conclude all the essentials that are there in the vestibular migraine. This is a 4-hour lecture, in fact, but I tried to concise in 40 minutes. So, thank you very much. So, next, Dr. Abhik sir will be speaking on the vestibular migraine and the Meniere disease complex. Yes, sir, please.
My questions are regarding to the imaging of endolymphatic eye drops.
Yes, sir.
What is majority of migraine patients? Like most of the time they complain that their headache is side locked.
Yes.
Means is suffering on the left side 90% or on the right side. So as you told that in the vestibular migraine, it is bilateral endolymphatic eye drops.
Yes.
So what happens in these kind of patients? Do they also have a bilateral endolymphatic eye drops, or it is unilateral? Who are having a side lock?
Side lock pattern.
Side lock migraine.
The side lock migraine. Sir, we have seen bilateral. I have seen bilateral. In my cases, I have seen bilateral, but in literature, I could not find in that detail. I was also searching for this. In my patients, I have seen bilateral, but even when I asked Michael von Breven, like, he told like, when migraine is so classical, why should I investigate for endolymphatic eye drops? This is the answer what I got from him during Bharati Society meeting. When there is a classical migraine, when there is a classical headache on one side, so why should I go for contrast enhanced MRI, particularly looking for endolymphatic eye drops?
I'd like to answer this. There are papers telling it is bilateral. Yes.
Yeah, there are some papers from Turkish authors and Egyptian authors, but what I am trying to say is from the authority. They say that they don't have enough evidence for that, but what I found is bilaterals, even in the side lock pair.
Thank you, sir. In your slide, you have written fermented alcohol should be avoided. It's a question from audience. Can we take vodka and whiskey?
Yes.
Yes, thank you. So next speaker is Dr. Abhik Sikdar, sir, from Indore. Sir is talking on Meniere's migraine complex.
Good morning, everybody.
at the onset, I must confess that I was basically an endoscopic surgeon, and it was COVID which pushed me to this, when I could not cut anything. And Dr. Srinivas has been my inspiration. So, I thank the organizers of ChakkarCon 2025 and Integrated Balance Forum to invite me to this historical city of Tehzeeb, Nawabs, Galoti Kebab, and Munshi Premchand's Satranj Ki Khilari. This was made into an epic movie by the master filmmaker Satyajit Ray. Vestibular migraine associated vertigo reminds me of Satyajit Ray's father, Shukumar Ray, who made iconic creations of animals like the stork-oils and the whale-fan, who had chimeric personalities. In 2001, our very own Professor Chakkar from AIIMS had attempted to categorize the types of vertigo-associated migraine. 4 distinct and characteristic vertigo types were identified, ranging from transient reversible dysfunction to permanent destruction. This implied involvement of both the peripheral as well as the central vestibular pathway. If you can make it, this is way back in 2001, long before the classification of vestibular migraine came into practice from the Baronic Society. Many of you have read Hamlet. To be or not to be, that is the question. So, if you see in 2004, Lempert stated that the entity vestibular migraine was missing in the International Headache Society classification. Brandt made a comment in the same section of Cephalgia 2004, and it is prophetic today. He was worried that the addition of this chameleon, check the word chameleon, what just Sir showed now, the chameleon way back in 2004. The addition of this chameleon may lead to more confusion than clarity. The consensus diagnosis of International Headache Society and Baronic Society requires definitive vestibular migraine to have, number 1, a current or past history of migraine along with 5 episodes of C or D. So what is C? C is vestibular symptoms of moderate to severe intensity lasting between 5 minutes to 72 hours. Moderate if it's only interfering with day-to-day activities, and severe if daily activities are prohibited. In D, there should be at least 50% of the episodes with one of the following 3 features, that is, headache, photophobia and phonophobia, or visual aura. Now, see the characteristics of the headache. The headache should have at least 2 of the following 4 characteristics, that is, unilateral, pulsating, moderate to severe intensity, or aggravated by routine physical activity. So what I'd like to tell you is that even without headache, if you have photophobia and phonophobia, just like Dr. Pradeep had said, you can still classify for a vestibular migraine. In case of probable vestibular migraine, there has to be migraine history or migraine features during the episode along with the vestibular symptoms. If you look at the classical criteria, it will not always fit, because now Lempert in 2012 had seen that 30% episodes of vestibular migraine may not have headache. 30% would last minutes, 30% hours, and 30% last days. 10% may have repeated attacks lasting only seconds, while some take months to recover. In 2015, Baronic Society classified Meniere's disease into a definitive and a probable variant of Meniere's. If you check, in both these, there must be fluctuating hearing loss, tinnitus, or ear fullness, and definitive spontaneous vertigo. However, now you check, in case of definitive Meniere's, the spontaneous vertigo may last between 20 minutes to 12 hours. However, in case of probable Meniere's, the sun and the sunrise and the sunset will happen together, in which it may last up to 24 hours. And always it is checked that it is not better accounted for by any other diagnosis. In case of definitive Meniere's, one more thing should be there. There should be audiometrically documented low to medium frequency SNHL in 1 year, either before or during or after one of the episodes of vertigo. Historically, in 1985, Paparella had described the variations in the clinical features Meniere's, in which there was fluctuation in hearing loss. To be noted here, though classically Meniere's disease has unilateral hearing loss, even in 1985, he had mentioned that it may be bilateral. There can be tinnitus, oral fullness, and vertigo, and this varies significantly with respect to the onset, duration, frequency, and the disease course. Most patients develop symptoms in 1 year, and with time, several years later, hearing loss and tinnitus may affect the second year in Meniere's disease. However, in some patients, they must show SNHL in both the years from the start. Hearing loss would usually become permanent as the Meniere's disease progresses, as seen in various studies. Nowadays, there is SatNav, GPS, and Google Maps, which tells me how to navigate the shortest road trip from my home Indore to your great city. Unfortunately, when differentiated between Meniere's and vestibular migraine, there is no such single investigative modality. On checking a historical recount of Prosper Meniere's description of his namesake disease, we see that it is mired in confusion with migraine headaches right from the start. So, Prosper Meniere wrote a series of 4 papers 1 year before his death. In one of these papers, he makes references to migraine headaches on several occasions. And just like you have seen people not listening to Cassandra, similarly, his colleagues ignored Meniere's theory concerning migraine headaches, but he kept on continuing the deductive inferences and published his findings, leading to the association of migraine headaches and Meniere's disease. Presently, this association, for I'm talking here, between migraine and Meniere's continues to be debated, adding to Prosper Meniere's legacy. So why is there so much overlap? There are various hypotheses. One would be the neurovascular crosstalk. So there is dysregulated trigeminal nerve activities associated with migraine, which could affect vestibular cochlear function by the neurovascular connection. The V1 nerve is involved with the posterior cerebral circulation and the cochlear vestibular vasculature, including the stria vascularis. Chronic inflammatory conditions in Meniere's disease stimulate the trigeminal nerve system in the inner ear, thereby inducing migraine. Moreover, dysfunctional trigeminal nervous system in migraine may cause vestibular neurotransmitter release and even endolymphatic hydrops. So just like we had said before, endolymphatic hydrops, though classically a feature of Meniere's disease, may also occur in migraine. So other various pathophysiologists considered was channelopathies, in which case brain calcium dysfunction was associated with migraine and episodic vertigo. Extracellular calcium induces the spread of depression in migraine and also endolymphatic hydrops. Chronic activation of immunoinflammatory nuclear factor and kappa B and tumor necrosis factor links Meniere's disease and migraine. Chronic hydrophic inner ear was vulnerable to migraine's attack because of the poor autoregulation of the endolymphatic flow. Moreover, the susceptibility to migraine as a result of stress and other psychological distress is elevated in patients with Meniere's disease. Similarly, both migraine and Meniere's disease has common trigger factors like the change in weather and diet. Like in the early modern ages in 1700s, we are left with multiple navigation instruments, that is tools, to distinguish between Meniere's disease and migraine-associated vertigo. These are 100% not accurate, but helps us to guide to some extent. In 2022, Kim published the association between Meniere's disease and migraine, in which around 7,000 Meniere's disease patients were matched with around 28,000 control participants without Meniere's. Similarly, around 36,000 patients with migraine were matched with around 72,000 control participants without migraine. Matching was done for the demographic characteristics, socioeconomic characteristics, lifestyle, and comorbidities, including other vestibular disease. A stratified Cox proportional hazards model was used to determine the hazards ratio. Meniere's disease was associated with a 2.22-fold greater hazard ratio for migraine. Similarly, migraine was associated with a 1.95 higher fold of hazard ratio for Meniere's disease. So, in plain terminology, what does it mean? It means that Meniere's disease patients has a higher risk of migraine occurrence and the other way around. So, based on this, it was postulated that based on the bidirectional association, therapeutics for migraine could potentially be applied to treat Meniere's disease and vice versa. Chen in 2023 published a paper, Vestibular Migraine or Meniere's disease, a diagnostic dilemma. What he found out in this was that vestibular migraine patients were usually younger females, while Meniere's disease patients were usually elderly males, older males. Here, in case of 50% cases of vestibular migraine, there was motion sickness. This suggests that there is a hypersensitivity to the visual vestibular mismatch in vestibular migraine patients. Moreover, in vestibular migraine patients, there was a stronger association with cognitive symptoms like somatic and mental issues. Vestibular migraine patients have a history of recurrent moderate to severe headaches. However, even in Meniere's, in some studies, there was around 80% migrainous headaches to be noted. There was some change in the characteristics between Meniere's disease and vestibular migraine. In Meniere's disease, vertigo persists longer, usually for several hours, wherever in vestibular migraine, the vertigo had more diverse presentations. In Meniere's disease, the hearing loss was fluctuating or progressive in type, because with time, usually they would get permanent hearing loss. On the other hand, in vestibular migraine, the hearing loss was bilateral symmetric and the progress was much slower. As we are talking of the head-shake nystagmus, we can also see there was a spontaneous vertical nystagmus. This was seen in vestibular migraine and could be explained by the central cause of vestibular migraine. Similarly, what Dr. Prateek had said, that there was a bidirectional swinging nystagmus in head-shake, similar to that. There was head-shake nystagmus present in 78% of Meniere's disease and 50% case of vestibular migraine. In case of Meniere's disease, the commonest head-shake nystagmus was a paratic head-shake nystagmus, with the nystagmus going towards the lesion site. We have all known the glycerol dehydration test. Glycerol dehydration test does not diagnose Meniere's disease. What it diagnoses is that it diagnoses endolymphatic hydrops. So in case of glycerol dehydration test, there was temporarily improved hearing in around 80% of Meniere's disease. ECOG-G, that electrocardiogram was done. This records the sound stimulation induced cochlear potential. A summation potential by action potential ratio of above 40% results from endolymphatic hydrop caused displacement of the basilar membrane. Sensitivity for the diagnosis of endolymphatic hydrop by ECOG-G was around 67%. In gadolinium contrast MRI, in Meniere's disease, there was both vestibular and cochlear involvement. In case of vestibular migraine, there was rare endolymphatic hydrops and usually bilateral. He further suggested that many patients with sudden or sporadic vestibular symptoms could not be definitely diagnosed under the current guidelines of either vestibular migraine or Meniere's disease. And this comprised a new entity. They comprise the RVS-NOS. What is RVS-NOS? It is recurrent vestibular symptoms not otherwise specified. This term was coined by Dugliach. And it is said that this RVS-NOS is likely moderate or insufficient or incomplete forms of either vestibular migraine or Meniere's disease. Subjective and objective response to calorie tests were revealed in 2024 by Hannigan, where he tested calorie tests on around 1,300 patients across the common vestibular disease. What he mentioned was calorie intolerance. What is calorie intolerance? Calorie intolerance is on calorie testing if there is nausea, vomiting, palpitation, limb numbness, or body stiffness. Vestibular migraine patients and other central disorders patients experience more calorie intolerance compared with peripheral vestibular disorders and non-vestibular dizziness. This was a landmark paper in 2023 where comparison of clinical characteristics and vestibular function tests in patients with vestibular migraine and Meniere's disease was done. Here 71 patients with definitive Meniere's and 31 patients with unilateral migraine Meniere's disease were included, in which calorie test, video head impulse test, and WEMP tests were done. Cervical WEMP and ocular WEMP detects the dynamic saccular and intraocular function. In his case series, he could not find any significant difference between the CWEMP and OWEMP between Meniere's and migraine. This is in contrast to the next paper I'm going to talk with you. What is calorie test? Calorie test is a non-physiological stimulation of the horizontal vestibulocular reflex in a low frequency range of 0.002 to 0.004 Hertz, and a canal palsy is diagnosed when there is a more than 25% decrease in the unilateral horizontal central canal dysfunction. This is taken as CT1, CT plus. The normal viewer gain for horizontal central canal lies between 0.79 to 1.2. In his cases, the saccades and the viewer gain were recorded. If there was a fall in the viewer gain along with the presence of saccade, it was taken as video head impulse test, that is VHIT test positive. What was the finding of his study? The finding of his study showed that in case of migraine-associated vertigo or vestibular migraine, there was a diverse nest of vestibular symptoms, especially internal vertigo. Now you must know what you mean by internal vertigo and external vertigo. Internal vertigo is a false or a distorted sense of self-motion, including spinning, swaying, bobbing, etc. And external vertigo is a false or distorted sense of surroundings. This you all know, but practically what is it? As Dr. Srinivas had told me a long time back, it is basically what a normal person feels during calorie test with eyes closed is internal vertigo, and feels with eyes open is external vertigo. So in case of vestibular migraine, there were symptoms of internal vertigo, history of motion sickness, again we are coming back and back to that point, a caloric intolerance. However, the calorie test and the VHIT test both were negative. In case of Meniere's disease, there was spontaneous external vertigo. Here the calorie test was positive. What it means is the one ear was involved more than the other ear, but the VHIT test was again negative, but there was presence of saccade. So as I was telling, in another paper by Abhik in 2020, he had taken 25 definitive Meniere's and 34 definitive vestibular migraine with 13 control subjects, where he said that if CWEMP or OWEMP is present, in 93% cases it would exclude Meniere's disease. CWEMP in Meniere's disease showed asymmetrically, because only usually one ear is involved, it showed asymmetrically reduced amplitudes on the affected ear, unlike vestibular migraine as well as healthy controls. WEMP response was symmetrically reduced on both sides in vestibular migraine patients, suggesting that otolith organs might be affected by the migraine-induced ischemia. On the other end of the spectrum of researchers, some consider vestibular migraine and Meniere's disease to be two sides of the same coin, like Mephistopheles and Margarita statue of Salajan Museum, Hyderabad, or a very own Orthonarishwar. Frank was frank enough to say that Meniere's disease is nothing but the manifestation of migraine. Because while in only 12% of general population there is migraine headache, in Meniere's there would be around 60% patients, and endoliphin hydrox, which is pathognomonic of migraine, for Meniere's, has also been identified patient with vestibular migraine. He suggested that treatment with the integrated neurosensory rehabilitation approach, that is diet, a lifestyle modification, along with migraine supplementation, and when required, prophylactic medication to treat the anti-migraine process, has been highly effective in patients with Meniere's disease. Ghavami in 2016 did a study in which he said that most patients with Meniere's disease had migraine headaches as defined by International Headache Society. Many migraine characteristics such as the family history of migraine, motion sickness and visual motion sensitivity, which are found in Meniere's disease, are there, though they do not fulfill the IHS criteria for Meniere's disease. Sensitivity to visual motion, head motion, light and sound, smell, we remember back, weather changes were present in 95% of all patients with Meniere's, definitive Meniere's, and in 82% patients where there was migraine feature, but this migraine feature did not fit into the classification of migraine as per IHS. And so he came to the conclusion that Meniere's disease may be an atypical variant of migraine. 2 years later in 2018, when evaluating the quality of life in patients with Meniere's disease treated as migraine, Gawami noted that majority of Meniere's disease patients who had failed diuretic therapy responded positively to medications used for migraine prophylaxis, as indicated by a significant improvement in the quality of life. So, taking to the bidirectional relationship between Meniere's and migraine disease, it was mentioned that Meniere's disease patients should be treated with migraine prophylaxis regardless of whether the IHS criteria for migraine is met or not. Here you are seeing two artists, a vocalist and a flutist, playing a duet. The vocalist represents vestibular migraine, who can mimic various instruments.
तो अपने आप में एक इंस्ट्रूमेंट है.
The flutist is Meniere's disease. And together, Meniere's disease and migraine may orchestrate a symphony of vestibular symptoms. So, this slide has already been there. There is a large overlap between Meniere's and migraine. Vestibular activation of Meniere's may provoke migraine. Migraine may also have tinnitus. Migraine may cause positional nystagmus, but this usually does not follow the latency and the crescendo-decrescendo effect of classical BPPV. In 2019, this paper came out where the ictal, interictal symptoms and the psychiatric comorbidities were checked in 131 patients. 80% of middle-aged ladies with personal history of motion sickness and migraine. The common triggers were stress, bright lights, weather change, and sleep deprivation, what Sir had said. Anxiety was the commonest psychiatric disorder, followed by depression, insomnia, phobia, and last but not the least, psychogenic disorder in 8%. Here, if you see, there were ictal symptoms present. In case 90%, there was photophobia and photophobia even in the ictal symptom, and interictal nystagmus was present in 42%. 50% of vestibular migraine patients reported almost constant interictal dizziness. 65% patients of this were triple PD. In triple PD, there is non-spinning vertigo dizziness for most days for at least 3 months. And in 3% patients, there was Maldi-Barbeque syndrome, which is also known as disembarkment syndrome. So some patients with initially episodic vestibular migraine will develop daily less severe vestibular symptoms that resemble triple PD, which is similar to episodic migraineurs who progress to chronic migraine, developing a daily subtle headache in between the acute attack. When checked for oral and perceptual symptoms, cochlear symptoms increased threefold in 9 years. 18% developed bilateral low-frequency sensory hearing loss on follow-up in case of vestibular migraine. Like in Meniere's, tinnitus and oral coolness were also common. In fact, if you look at this paper, tinnitus could occur even more frequently during the interictal period in vestibular migraine. Coined by John Todd in 1955, Alice in Wonderland syndrome causes distorted perceptions of time, place, vision, hearing, and touch sensation, and also of body parts, something similar to the experiences of Alice in Lewis Carroll's classic novel, Alice's Adventures in Wonderland, where sometimes she was thinking she was very small, sometimes she was thinking she was very large. So, what is this Alice in Wonderland syndrome? It is seen that in 14% of vestibular migraine patients, they would develop perceptual symptoms of Alice in Wonderland syndrome, of which the commonest was visual distortion like illusory splitting, underwater vision, xanthopsia, and dolly zoom effect. Now, what is the dolly zoom effect? Dolly zoom effect is a distortion of the visual perspective produced by zooming the camera lens onto an object while simultaneously moving the camera farther from the object in a way so as to maintain the object size in the frame throughout, causing the background to change in size relative to the object of interest. To be noted here is that the dolly zoom effect was first conceived of and used in Alfred Hitchcock's famous movie Vertigo. So, around 30% patients will have somatic distortion like body parts feeling too big or too small, and there may be bizarre symptoms like the Alice in Wonderland syndrome. So it is very easy to misdiagnose a patient who is having vestibular migraine to a purely psychiatric etiology. In 2024, cluster analysis revealed cochlear symptoms to be a defining part of the phenotype. If you look here, you will see that both symptoms orienting towards the peripheral mechanism, that is the cochlear symptoms, and a central one, that is long-lasting positional non-transient vertigo, may coexist. This paper came out in 2024. To be noted here is that this is similar to Alak Thakkar's paper in 2001 in AIMS, which also said the same thing. So when evaluating patients of potential diagnosis of vestibular migraine, you must look beyond the vertigo. So this is a paper I would always like to quote. There's something known as the pupillary cycle. The pupil dilates and contracts cyclically in the presence of constant lighting, mark my words, constant lighting, and the rate is between 0.04 to 2 Hertz. The exaggeration of this phenomenon is usually termed pupillary hippus. Both pupillary hippus and migraine occurs due to abnormal activity of the autonomic nervous system. Pupillary hippus was suggested to be taken as an objective sign because it is also present in the intellectual phase by Buffoni. He suggested that it should be included in the international diagnostic criteria of vestibular migraine. The take-home message from the land of Lucknow chicken embroidery would be to avoid ablative therapy in Meniere's disease like intratympanic gentamicin, vestibular nephrectomy or labyrinectomy. And based on the bidirectional association, treatment of migraine could be applied to Meniere's disease and vice versa. Meniere's disease patients should be treated with migraine prophylaxis regardless of whether the IHS criteria of migraine are met or not. And treatment with integrated neurosensory rehabilitation approach like diet and lifestyle changes, magnesium supplementation, and when needed, prophylactic medication to treat migraine is highly effective in patients with Meniere's disease. This is the place I work, Chakkar Hospital, Indore. Indore has been awarded 8 times Finest City in India. We run a DNB program in ENT since 2017 and it's the only institution in MP to do the same. So, in the epilogue, in this integrated balance forum, I'd like to emphasize that diagnosing and treating vertigo is no longer mission impossible. And ENT specialists like Srinivas sir, Prateek sir are showing the way. Thank you.
Abhik sir ko bolo.
So, don't embarrass me.
Considering the pathophysiology of vestibular migraine or Meniere's disease, do you suggest any particular type of migraine prophylaxis amongst the medicines available?
Sir, I'll tell you what I do in my daily practice. I would use. No, sir, I have not. No, sir, I have not gone. I have not got anything of that sort. This is all scientific evidence which I've quoted. In my daily practice, what I do is I will usually get topiramate because it has less side effects. Other than in the if somebody is preparing for a child, it causes loss of weight because most other drugs causes gain in weight. So I usually start with topiramate.
Will be positive in case of migraine also?
The glycerol test shows endolymphatic hydrops. In case of Meniere's disease, endolymphatic hydrops is much more common and it is usually 1 year.
Right.
The
But as it was said that the hydrops is seen
that is what I'm trying to tell. That is what I'm trying to tell you. There is no single shot which fits all. End of the day, as I said, some people consider it just two sides of the same coin.
Okay. And about the, in one of the slides it was mentioned, the hearing loss is a low frequency sensory neural hearing loss in migraine.
So this is what the paper says.
Okay.
Okay, thank you. Thank you.
Sir, I would like to add regarding the query what you have asked. Whether it is Meniere's disease or vestibular migraine, one kind of drug that can take care of is usually flunarizine. Even there are 3 or 4 papers that are being, one of the co-author was Thomas Brand. In that, what they said was the flunarizine can be given in cases of doubtful overlap syndrome or doubtful cases. Coming to my experience, I do regularly vestibular nerve section for this Meniere's disease, even though Sir has told not to do, because Meniere's is a dynamic disease which reduces the vestibular compensation. So obviously you have to give a stable platform on the disease side, so that if you can make it 0, the brain can compensate for the whatever. So even in these cases, proven cases of Meniere's disease, the results are very good with flunarizine till the time I operate. And if someone asks me, I don't know about all the people, if someone asks me one good drug that everyone should believe, it's not beta-histine for me, it's flunarizine. Flunarizine works in most of the conditions. But of course, being a neurologist, you should guide us or advise us on this regard.
Unfortunately, the flunarizine company did not use the brand name Vertine. Okay, because of that. Otherwise, flunarizine would be. But the one biggest side effect, may not be that common. The biggest side effect of flunarizine, I'm not that much bothered about weight gain also, I am not that much bothered about Parkinson's also, is depression. Very bad depression.
Suicidal tendencies.
No, in people who are susceptible, you will see that even in the first month. First month itself.
How long should it be?
Sir, if it is not an issue, if the person is not having a problem, no depressive things, they're really feeling good, then any long is okay. In the sense, but it's a good practice. Now I use flunarizine in 3 ways. One is a battery charging way, which was taught by Dr. Sushma Sharma, who is a neurologist who practices in near Delhi. Then the other 2 options is like abortive, pulse therapy, and the long-term therapy. The abortive therapy is that, unlike what is taught in the textbook or whatever, flunarizine is a very good drug, like a painkiller. In fact, when you get an actual attack of vertigo or an actual attack of headache, even at that time, flunarizine is able to resolve the headache and resolve the vertigo attacks. But that's okay. It is working. That is the clinical.
Just say observation.
Yeah.
Just
It's an observation.
when you analyze something compared to use something impressive.
If it has, see, personally, I also take it. Okay. So we have seen nystagmus stopping within half an hour after taking it. Okay. So like that, it does work. In fact, second thing is about, in the sense when the attack has happened or when the attack is about to happen. A lot of people have a premonition that the attack is going to come. Sometimes we give it before a travel. Okay, because of any travel is there, whatever is there, they know that a lot of stress is going on. At that time, we give flunarizine. That is one thing. Second one is a pulse therapy, 5 to 10 days of flunarizine. Whenever an attack comes and fully setting, 5 to 10 days and stop it. The last one is the battery charging approach. You give for 1 month and you expect the effect to last for up to 6 months, like that. So like that you can use flunarizine. Within, yeah, but then it stays on.
A steady state level of comes
Yes.
How do you expect that you can work so early
Yeah.
that you, once a patient has vestibular migraine a day,
Yeah.
give it for 5 to 6 days,
Yeah.
then it's subsiding also. Right. Take few weeks to take this steady state. That's why once we start as a vestibular migraine,
Yeah.
we wait at least for 2 months before seeing whether it is effective or not.
So maybe we should just dive deep into how this is working.
whether it is the steady state levels or it is the immediate action or what exactly is bringing. Like when it comes to antibiotic amikacin, we are not bothered about the steady state level. It is just amikacin entering the blood and it develops the kill. So maybe we can. It does work on exercise. In fact, in my bag, I have a flunarizine stick all the time. Okay. Whenever I feel nauseous or whatever it is, like I take back to the back flight sometime and all of those things. When I'm finished and I'm about to, I know that I'm getting the attack or I start feeling nauseous or whatever it is. I need to go to some place. Just take a flunarizine. The best part of flunarizine is, though it is not marketed like that, it works as a mouth dissolving also. I put it in the mouth. By the time I reach the place, like in the cab or whatever, where I'm supposed to go, by then it's all settled and fresh.
So if the patient is not responding, then you use
20 also. I give 20 also. I give up to 20. Not cross 20, but I give up to 20.
Single-dose coordination half-life is only 5 to 15 hours. As you use the long elimination.
Steady state.
Steady state is
This doesn't guarantee that it is going to be effective.
Yes.
Need to say this is steady state.
So I think we can start the next topic, that is understanding nystagmus. This is very important for all of you, especially the junior residents, the senior residents. And you have to understand nystagmus or the eye movements. My main motto of doing this ChakkarCon 2025 is, once you go out and you practice in your clinic, so it is coming upwards. Hello? Okay. So once you go out, you should at least do one thing, that is do a disulfide test in your clinic. So this is the context for this particular topic. So I will be talking about what is nystagmus, what is positional nystagmus, and I will show you some rare forms of nystagmus also. And I will keep it very short. So this is the most common type of nystagmus, which is known as horizontal nystagmus. This is the graph of the nystagmus. A nystagmus is termed as true nystagmus if it has a jerky pattern. Jerky pattern you have all read. So jerkiness means there will be a slow phase, there will be a slow phase, and then there will be a fast phase. This is apparent here very well. You can see this is the fast phase and this is the slow phase. So if you see this pattern, then only you can say that this is a nystagmus. So nystagmus can be of horizontal, vertical, torsional, and mixed. So this is a typical horizontal nystagmus. Convention of this is my left eye, this is my right eye, and if the eyes are moving to this side, it is right beating. If the eyes are moving to left side, it is left beating. Similarly, if the eyes are moving up, it is up beating, and down, then it is down beating. Are you able to see the video? So is it vertical nystagmus or torsional nystagmus? This is a horizontal nystagmus. And is it a left beating or a right beating?
Both directions.
Left.
Left beating. This is a left beating nystagmus. So most of you say that, sir, I don't have any sophisticated device. I am very busy in the OPD. How can I diagnose BPPV patients? Just do a disulfide test. If you do a disulfide test, you can see these type of nystagmus. Can anyone tell me what is the nystagmus? Horizontal. Yes.
क्या है आप क्या कुछ बोलेंगे?
What is this?
It's a long time. Irregular.
This is not downbeating nystagmus, please understand, because with the reference of face, it is moving in horizontal direction. Okay? And this is going down, and this is, the eyes are going up. Okay? So now, just by seeing one video, you should not tell whether it is geotropic or apogeotropic. You have to see on the both the sides. Second point is, you should do disulfide test on both the sides, every time. right also and left also. Most of the time what we do is we see an nystagmus on right side, then immediately we go for epilepsy. No, we have to wait and we have to see on both the sides. Okay, so this is a horizontal nystagmus beating to the left side, that is horizontal nystagmus beating to the right side. And yes, your diagnosis is correct. This is geotropic horizontal canal BPPV, and that is apogeotropic type of lateral canal BPPV. So, can you see and tell me in which plane the eyes are moving in this? Is it a horizontal plane or a vertical plane?
Vertical plane.
Vertical plane. This is most difficult to understand whether it is upbeating or downbeating. Okay? But in this, if we look closely, just use your mobile phone and record. You can always play it back slowly. And if you play it back slowly, you can see that this is a downbeating disturbance. Okay?
And there is supposed to.
No, ma'am. Not much. Now, this is the most common nystagmus which you will see. This is actually a positional video. So now the patient is going into the dependent position in the Dixolpite test. And can you differentiate the eyes that it is not exactly moving vertical, it is torsional. Yes? So this will give you money. If you see one BPPV patient and if you diagnose one posterior canal BPPV, you can say abracadabra and do a Dixolpite test, do a please, and you can say I have treated you without giving any medication. Because all these patients are generally left with other tablets and all. That is why you have to do just a Dixolpite test and understand how things work. If you see this, you have to do a particular maneuver and then it is treated. Do you want me to play this again? Torsional nystagmus? Yes? Okay. I will play it again. The most common BPPV patient will be this only. Can you see? Okay. Yes, it is posterior canal. It is posterior canal, but which canal? That Dr. Srinivas sir will explain in the further lecture. So this is in actual OPD. Can you see it also in nystagmus now? Yes. Sometimes you have to hold the eyelids like this because once the patient feels that it is vertigo, they tend to close the eyes. Okay, so this is a typical posterior canal BPPV which you can see in your OPD. So there are three types of nystagmus. This is jerk nystagmus. You can see fast phase and the slow phase. It can be torsional, horizontal and vertical. Then there can be different type of nystagmus in which the slow phase has a increasing velocity slow phase and a decreasing velocity slow phase. Can you tell me what nystagmus is seen in this video? Yes. Why pendular? Because in this we cannot differentiate the slow phase and the fast phase. Okay? And this patient came to me for allergy, not for vertigo, not for anything. Because pendular nystagmus, in pendular nystagmus patients, the vision is normal and generally they don't have any other problem. And in the graph you can see it is very hard to explain whether it is two slow phases or two fast phases or a slow phase and a fast phase. So if you get this graph and this video, it might be a pendular nystagmus. So this is an interesting patient. This patient had hearing loss on both the sides. So I am asking him to look to one side.
सीधी तरफ देखो, इधर देखो, सीधी तरफ देखो, सीधी तरफ इधर, ऊपर देखो, नीचे देखो, उल्टे हाथ देखो,
What is this?
नीचे देखो, नीचे
The eyes are doing Kathakali, that too very fast. So this is a pendular nystagmus. It can be a congenital nystagmus. It can be acquired pendular nystagmus also. The differentiating features with pendular nystagmus is it changes the direction when you change the gaze. So right gaze will be different, left gaze can be different. On looking up and looking down, it can be different.
And one more characteristic is that it has a null point.
It has a null point. That is what I was checking. Yes. Yes. That is why initially, when I was talking to him, there was no nystagmus. When I asked him to move to the right side, left side, then the nystagmus started. Similarly, this patient, he has hearing loss and cataract, I think. Congenital cataract, and his vision is perception of light, and he is having this nystagmus. So if you see this nystagmus, there is nothing to worry about because you don't have to do anything. So this is how a pendular nystagmus will look like. It will not have a jerky pattern. Now coming to saccades. Saccades is when from center position we look to either right side or to the left side and we hold the gaze. For example, I am standing like this and I am looking at Abhik sir. So what I did is from this particular position, my eyes made a saccade and now I am looking at Abhik sir. So this is normally how we do saccade. But in this patient, we can see that there is a nystagmus. There is a nystagmus when the patient is looking to the right side. So this is a nystagmus intrusion which can be seen in few patients of acute vestibular neuritis. Okay, so in this video also we can see that whenever the eyes are going to the right side, there is a right beating nystagmus, while on the left side it is normal. If you get a picture of right beating on the right side and left beating on the left side, then it is termed as gaze evoked nystagmus. Generally, gaze evoked nystagmus are central conditions. So you have to rule out central disorders also. And in few patients, it can be due to carbamazepine and other drugs also. This is a very interesting nystagmus. I will show you the video first. This is for all the neurologists. So whenever the patient is looking down, he is getting a downbeating nystagmus. While looking up, the patient is normal. Can any neurologist tell me the differential diagnosis in this patient?
Arnold Chiari malformation, CV junction anomaly.
Chiari malformation, okay. And? So this is not positional ego. This is normal. The patient is sitting and just looking up and down. Any other differentials? Cerebellar degenerations, brainstem lesions, multiple sclerosis can present in this way. The upward or the vertical gaze holding is done by INC, that is interstitial nucleus of Cahal, and RIMLF. If you see only this pattern, you can pinpoint in your mind that, okay, I have to look at this particular point in the brainstem. RIMLF, you can write in your MRI form that I want to see this particular thing. So just by looking at one graph or one video, you can be sure that I am pinpointing this particular structure and you can get a diagnosis. So this is how a graph of periodic alternating nystagmus will look like. So from right beating nystagmus, after few seconds it changes to left beating nystagmus. And in this below graph you can see that within 5 to 10 seconds the nystagmus has changed the direction. Most commonly after 180 seconds the cycle changes, but in few patients like after 90 seconds also the cycle can change. I will show you the video. So this is a very interesting video for neurology residents. Can anyone tell me what is the problem in this video? Any problem? सर आप सीनियर हैं सर, उस आंख को देखते हैं, ठीक है? ये इधर नहीं जा रही, ओके, इधर जा रही है.
Left lateral rectus palsy.
Yes. So this is left lateral rectus palsy. So that is why we have to see the eyes. We have to see the videos. And the graph will look like this. Normally, both the eyes should move together. But in this graph, we can see the left eye. I think this is not the real graph of this particular patient. Left eye is going aram se, but right eye is not able to go up to the top. So this is lateral rectus palsy. What are the causes of lateral rectus palsy?
Headache.
Yes, most common. If there is a female, 30-40 years, headache, IIH can be there, BIH can be, it is most common. And in MRI also you can see empty cell syndromes, etc. So, next this. Now what is this?
Bilateral lateral rectus palsy.
Yes. One thing I missed in the previous patient was to do a convergence test. So this is bilateral lateral rectus palsy. Now coming on to this second last video. Look at the left eye. Now the left eye is not moving medially. This is again referred to neurology. ENT अपने पास नहीं रखना है. So this is INO. Should I play the video again? This is a very simple test which you should do in your OPD. It will just take 30 seconds. एक बार left right ऊपर नीचे. And all these videos are given by my friend Dr. Ravindra. He is an ophthalmologist practicing in Hardoi. Okay. Sir? Sir, वो भाई है वो कर देगा. उंगली को देख कर ठीक है. Now this is a 500 rupees question. If anyone can tell me.
Heterochromia editor.
Sir, आप रुकिए तो sir.
There is no movement on sir. वो 500 say if you have waited, you would have paid 1,000, 10,000, then you give the answer.
Okay, tell me.
Horizontal there no movement नहीं है
Left eye is not moving.
Yes.
False eye है.
Sir, आप senior आदमी हो sir. आप. Anyone else? I will play it again, okay? It's a very good video. Right eye is moving. Right, left.
Left eye is not moving at all. Remove कर दिया.
सर न्यूक्लिएटेड आई में आई बैठा हुआ है.
This is a artificial eye on the left side. So इसमें refer to neurology नहीं लिखना है. Now this most of you have seen, might have seen during VNG, that once you close the flap and once you are doing a Dixolpide test, you see that both the eyes converge like this, and then there is an nystagmus also. So what we should do in this patient?
MRI.
फिजियोलॉजी कन्वर्जन. फिजियोलॉजी कन्वर्जन.
No, this is convergence retraction.
मैडम 1000 रुपए का आंसर है अब.
Convergence retraction nystagmus.
Convergence retraction nystagmus.
Migraine is what it is.
So will you do an MRI or?
Yes.
And 1,000 rupees की बात है, 1000 रुपए की बात है. So this is physiological. Any patient, when you are in blind, if you don't see anything.
So 500 rupees.
अरे sir. So the only purpose of showing this video is, this is not central. ठीक है, इसमें we have to also see that, look at the pupil size. जब भी eyes actual में converge होती हैं, they produce a miosis also. So this is when the patient is not seeing anything, sometimes they converge. So this is how they converge, and this is a convergence spasm or physiological convergence, so you don't have to do anything. If you see it repeatedly, बार बार आपको मिल रहा है, then you can ask for an MRI. So thank you so much. I think I have not confused you that much.
So,
that excessive convergence tone that happens on removal of fixation.
This excessive convergence tone that happens on removal of fixation, because in the goggle, when we put the visor, the visual reference of what is straight ahead goes off. And when the visual reference of what is straight ahead goes off, a lot of people are able to keep their eyes straight ahead. But a few people may take the eyes to convergence. In the beginning days when we started seeing this kind of phenomenon, we didn't have an explanation. So we thought maybe something will show up, and we have done multiple patients MRI scans, and most of them turned out to be negative. But MRI negative does not mean that it doesn't have an implication. So not everybody shows convergence on removal of fixation. A lot of people are just able to look straight ahead on removal of fixation. So on removal of fixation, when people converge, it means that there is a hidden excessive convergence tone. There is a tendency for convergence, or there is an excessive convergence tone, which in the presence of fixation they are avoiding to keep. This could probably have implications. In the sense, we also see, maybe we can do a proper study and see how many of migraineurs actually show this phenomenon. So if migraineurs are showing this phenomenon, maybe convergence, extra convergence tone is part of the pathophysiology of migraine. Or they have a physiologically excessive convergence tone, and during going about their day-to-day life, they are actually actively fighting that convergence tone, which makes them more prone for migraine. So one of them could be there. So maybe this it is not like it for sure doesn't deserve an imaging based on that thing, unlike the other findings, but it can have implications. It can have implications. We are not, see, for example, hippus, we are not bothered about hippus. We used to see for. Now, because of migraine, we are seeing hippus in a new light. We really don't know what is the verdict there, because there is one study by Buffoni about hippus. We really don't know the verdict, because we have started seeing hippus in more detail nowadays only after the Buffoni's paper came. Which of these is actually significant in diagnosis of migraine, whether the amplitude is more important or the frequency of oscillation is more important, we really don't know. So eventually it will come. Maybe similarly this also can be part of that. We can start noting how many people show a convergence, and once the convergence happens, convergence reversal nystagmus automatically starts appearing.
So next we are going to have Dr. Srinivas talk on BPPV. So before that, I would like to invite Dr. Aniljan sir to be the chairman of this session, sir, and Dr. Vinay Agarwal sir to be the chairman of this session.
Past 1 o'clock. How many of you are hungry? Hungry for knowledge. Very good. Hey, look at this. So this is a two-part presentation. One part I'm going to cover, and the tips and tricks Dr. Pradeep Vundavalli is going to cover. In fact, vertigo for all practical purposes and for a large majority of purposes is migraine and benign paroxysmal positional vertigo. So in the morning also I told you, if you want a seal of vertigo practitioner, vertigo specialist on your clinic board, if you master these two things in the beginning, rest will follow. So we need to know BPPV and migraine well. This is the most important thing. Now, Dr. Prateek was telling about something in the morning. He has an aim. Entire ChakkarCon. The aim of ChakkarCon is that he wants people to go back and start doing only one maneuver, and that is Dixal-Pike maneuver, is what he was telling. So before the aim, we should start off with where we are. So maybe we can enhance the aim, or we can make the aim bigger, better. Is that correct? So how many of you are already doing Dixal-Pike maneuver? Your aim is already done, boss. How many, please raise your hands again, already who are doing Dixal-Pike? So after Dixal-Pike, definitely whoever is doing Dixal-Pike maneuver is doing Epli maneuver, is that correct? Who is doing a Guffoni maneuver? Who is doing a Jacobino maneuver? Done. I think have lunch and close the. Your aim is done, over. Everybody is doing everything. Perfect. Okay. Now we will get into a little bit of. So this is good. Now let me now have the other question. Who has never done a single Dixal-Pike maneuver? Raise your hands. Only one. So other people are also doing, correct? No, because see, the way I am going to approach the next half an hour is based on where we all are. Okay, that is why it is very important to know this. So everybody has done some kind of Dixal-Pike maneuver. Is that correct here in this one? Can I assume that way?
Yes, sir.
Okay. It is like when it comes to Guffoni, not everybody has done. When it comes to Jacobino, very few people have done. So this is what is the overall distribution here. So there are people who are already doing Dixal-Pike who have a different set of difficulties. There are people who are not started or little bit of Dixal-Pike or not, but have a different set of difficulties. We'll deal with each of these things separately. First and foremost is to understand what exactly is benign paroxysmal positional vertigo. In the morning when we started off, I was telling that the inner ear, there are three parts. The cochlea takes care of detection of vibrations from the air. Is that correct? That is the cochlear function. The utricle and saccule does a different job, and that job is, it is in the textbooks called as linear acceleration. For practical purposes, most of the time, its job is to detect the line of gravity. Is that okay? That is the third one is the semicircular canal. Semicircular canal's job is a camera stabilization. Okay, camera stabilization function. What is this camera stabilization function? We need to understand a little bit more. That one is, when you see the olden days, when we were all kids, we used to have cameras which were based on Fuji, Kodak films. We used to buy the film, we used to insert that, and then we used to take photos. And the elders always had a problem in giving the camera to the kids like us, because we try to take a picture, we are okay, but if we shake the hand a little bit, it all is off, okay? Blurred image, and it is one film wasted. Not like today where memory is cheap. You can take a photo, you can take one photo like this, one photo like this, with a tongue out, tongue in, do all these things and do all the photos. We are not bothered about it. Sahi aaya, nahi aaya, no problem. But those days it was not like. What is happening? Why were they not giving the thing to our hands, the camera? Is those days the cameras did not have a facility called image stabilization. What exactly is this image stabilization function? I will come to it. But before that, what is a stable image? What is a clear image? What is a sharp image? Our retina works like a camera. When you look at a video, it is nothing but a series of images. Video is nothing but series of images. So when you take one particular picture, let us take the consideration of this one thing. When I hold a camera or my retina like this, a particular location, say this particular light line bar is there, there is one corner of that. has a X, Y and Z location in the world. Is that correct? Now, when I am trying to take an image of that through the lens systems of the camera or of the eye, that is projected onto a particular X and Y location on the retina or on the pixel. Is that correct? Now, there is something else. Whatever the capturing the picture may look instantaneous, it is not instantaneous. There is some amount of time up to which that particular XYZ location representation should fall on this X and Y location. Is that clear? That is called the readout time, or the time up to which it is read and then read out. That is the acquisition time. Is that okay? In the retina, it is about 20 milliseconds. In the camera, depending on the frame rate, it is 10 milliseconds, 20 milliseconds, 40 milliseconds, like that. Okay. In the previous version of the video nystagmography that I made, that camera had a acquisition rate which required about 40 milliseconds of processing for each. The present video nystagmography system, which is 100 frames per second, okay, very advanced and unique and the best in the world, okay, which is 10 milliseconds. So something like that. Now, what is this 10 milliseconds means? For 10 milliseconds, the sensor is capturing what is coming from it. Is that clear? Sensor is going on capturing what is coming from it. Thus, for that 10 milliseconds or 20 milliseconds, whatever, that XYZ location, that particular light belonging to that should fall only on that XYZ cone cell only or rod cell only. Is that okay? Now, if you take a readout, you will get a sharp image that is occupying in the XYZ. Is that clear? Now, there are two problems. Within that 20 millisecond, if that starts moving, that same area light, instead of occupying one XY location, it will start moving to the next location. Is that clear? Instead of occupying one pixel area or one cone cell area or one rod cell area, it will start occupying 2 or 3 rod cell area, 2 or 3 cone cell area. Clear? Now the image that is read out, how will it look like? Instead of occupying one particular location, what is a dot? Instead of appearing like a dot, looks like a short line. What is that? One straight line looking like a straight sharp line, it looks like a moved line. What is that? That is what we call as blurring. Is that correct? You are all with me so far or hungry? With me, no? You are there, I know. So all of us together? So far? Now, there are two ways in which, and in the life, this movement of things, objects is constant. It is always happening. And to keep the camera itself, or human beings, or whether the camera, that movement is also happening. We need to have a strategy where, despite of the movement of the object of interest, or despite of the movement of the camera holding person or camera itself, this relative movement of the XYZ location and the retinal coordinate or the camera coordinate should not change. We need to mitigate that problem. That is the camera stabilization. Is that okay? It is done in cameras in a very beautiful way. That way is, when the camera turns up like this, the lens mechanics turn down like this. Okay, this is the IS, image stabilization systems, or vibration reduction system. If you use a Canon, I think it is called IS, and if you talk about Nikon, it is called as VR, okay, vibration reduction system. Basically, this is what they do. What happens is, when the camera is going up, the lens mechanics change a little bit so that that XY location is still maintained till that readout time is happening. That is one way of stabilizing. In the human beings, in the animals, in all these things, this image stabilization system is what is called vestibulo-ocular reflex. It is vestibulo-ocular reflex. What does the image stabilization system require? Image stabilization system requires that the holder of the camera, how much that person is moving has to be detected, so that the lens arrangement in the camera can be moved in the opposite direction by the same amount in real time. In real time is within the readout time of that 20 millisecond that correction happen and these things have to happen. This is vestibulo-ocular reflex. The detector of the camera holding system, that is the head, how it is moving, is the semicircular canal. The mover is the extraocular muscle. The mover of these things is the extraocular muscle. So for all practical purposes, semicircular canal is an image stabilization system. It is a contributor for sharp vision in motion. Sharp vision in motion, that is the thing. We need to practically see this. Theory is excellent, but we need to practically see what exactly this semicircular canal does. For that, we need to have our cameras on. We all need to stand up. Take your phone. Switch on the camera app. Even family members can participate. Switch on the camera app. If there is no space, move into a place where there is a space. Okay. Look at your own beautiful photos, focus them on your face. This is called self-love, the best form of love. Okay. Now look at, focus on your eyes. Video option. Start the recording. Now don't look at the camera. Look beyond the phone, look at the walls while ensuring that your eyes are staying focused. When the recording is going on, turn right like this. Don't look at the camera. Look at the walls and turn. Look at the walls and continue to turn. Stop. Play. What did you see?
Horizontal nystagmus.
All of you are able to see the nystagmus? Raise your hands.
Yes.
Who did not see the nystagmus cheated us by looking at the camera while rotating. Okay? Or you forgot to start recording. Do you all see the nystagmus? Yes. If you didn't see, if you want to repeat the experiment, you can repeat the experiment. This is physiological. Is that okay? Now the next part of the experiment is, we are going to do the same experiment, this time by focusing on the camera. I'll repeat that. We are trying to get an intuitive understanding of PPPV today. Focus the camera and do that. Did you do that? When you focus the camera and do it and play, you will not see the nystagmus. Did you see the nystagmus? So now, we saw while not looking at the camera, you saw nystagmus. While looking at the camera, you did not see the nystagmus. Now without the camera, we are going to repeat the experiment, but make a different observation. That observation is this. Now, put your thumb front, fix on the thumb. This is equivalent to focusing on the camera, is that correct? When you fix this and when you turn like this, tell me what happens to the background.
Blurred.
Is it blurred, the background? Yes. Clear? Now, when you did not focus on the thumb and allowed your eyes to move and went like this, was the blurring there?
No.
There is no blurring. Is that right?
So the conclusions of this study that we just did is, in a situation where, please sit down all of you. In a situation where, see, the beauty is for the camera person, he got something to record. Otherwise, he was looking one boring person standing here and living on top. Now he got to see all the beautiful places. So the recording is more nice. Correct, no? So the conclusions of this experiment is this. When you are looking at the walls and when you turn, your eyes oscillated. When you are looking at the walls and you turn is also the time when you got a good vision. Little bit counterintuitive. When your eyes are shaking, you got a better vision. The next time when you fixed your eyes on top of the thumb and then when you went around, the surrounding was smudged. It was like it was washing from one side to the other side. Washing out effect you got. Is that correct? You all agree?
Yes.
So basically here, eye movement gave you stable vision. Abolishing of eye movement when you are actually moving actually gave you poorer vision. What was happening? When your eyes remained fixed and when your that same XYZ location kept washing on the retina to different XY locations. It didn't occupy one rod cell area or one cone cell area. Just went on to all the particular, this thing during one acquisition time of 20 milliseconds, it was occupying different. So what you got? You got a smudged view. But when you actually developed a nystagmus, what happened was, when I'm looking straight like this and I started rotating, the eyes remained fixed with respect to that particular frame. Okay? It went. Finally, when it can no longer move in the orbit, then it just changed and started looking at a fixed onto a new frame. Then it started going to other side. Then it comes to a new frame. This is what caused the nystagmic oscillation. But at every point of time, I ensured that this eye was always, it was, I means this eye, not I, the ego eye. Okay. The eyes ensured that this was at one point of time holding on to one frame only, and that went on for some amount of time so that that stable vision was possible. Is that okay? This is done by the semicircular by detecting the movement and then moving the eyes in the opposite direction. Now you are made a divine engineer. Okay, you are made a divine engineer, or you are made an evolutionary engineer, whatever you want to call it. Now you have to make the mammalian vision stabilizing system. Is that okay? You have been given this power. You have to design the vision stabilizing system. You are given a set of sensors and you are given a set of motors. Okay, fine. Like for example, the stretch reflex. Stretch reflex as a sensor, that is the Golgi tendon apparatus, which just detects the spindle cells, which detect the stretch on the muscle. And when you stretch by tapping the patellar tendon, there is a contraction in the muscle. Is that correct? So this is an example where the sensory stimulus can itself be the origin of a motor signal. Is that correct? A sensory stimulus becomes the origin of a motor signal here, coming from there, going to the spinal cord and coming back. And when you see that, the best purpose is served by this, whichever muscle is stretched, that same muscle is the muscle that is being contracted. Is that correct? And that is what is helping us in the walking, because in the walking we have the central pattern generators. On top of the pattern generator, small changes has to be accounted for, which is being accounted for by this inbuilt stretch response. Here, there's a beautiful pattern. That sensor, the corresponding muscle. Is that correct? Now, if you are a designer and who is doing this image stabilizing system for the eyes, if I give you 3 sensors and we are not mathematically endowed with so much, doctors, we are happy with doing addition, subtraction, multiplication. With the difficulty, some division. Correct? No. If somebody tells a plus b the whole square, a square plus b square plus 2ab and all those things, up to there we can stretch our imagination. A plus b the whole cube means gone. Is that right? You are all in my shape, or somebody is can tell the cube also formula? Nobody, right? We are all. Abhik sir knows. शायद पार्ट टाइम में IIT बच्चों को सिखाया होगा, सिखाया होगा.
I got into engineering also, I didn't take it.
You didn't take it. अगर सिखा रहा हो तो that is a different issue. Now this discussion part is important. Now if I tell you, I can tell, I give you a sensor which will move, which will detect any movement that is happening in the horizontal plane. I also give you a set of motors. Will you place the motor in the same plane, or will you place two motors in different planes, do all the complex calculations to find out how to move those motors so that you are understanding? One of you can come here. If I'll tell you, I'll give you one sensor. If you place one sensor in the horizontal plane, whenever the head moves in the horizontal plane, your eye can move. You are given a motor. Will you place the motor in the horizontal plane, and then simply whenever a signal comes of the horizontal movement, move the eyes horizontally, or will you just to place one motor here, calculate, do the calculation, ये इतना खींचो बाद में वो straight ही आएगा. Which one would you prefer? Same plane, simple, keep it simple, correct? Take a sensor, take a motor, place them in the same plane, life is easy. No need for complex calculation. Even neurons also do calculations, it wants to keep the calculations minimal. Is that correct? You all agree? Yes, thank you. And when you actually study, and this is the most clinically important part here, study these sensors. What are the sensors that detect head movement? Here, rotations of the head. These are the semicircular canals. When you see the sensors, there is a horizontal semicircular canal, and the divine design is that there is a horizontal canal placed horizontally. There are exactly medial and lateral recti placed in that plane only. Whenever this gets stimulated, the medial and lateral recti are the ones that get activated. One inhibits, one exits, and the eye moves. Make sense? Now, when you look at the posterior semicircular canal, the plane of detection of the posterior semicircular canal is this plane. Okay, this orientation. Is that okay? When you look at that particular orientation, something very odd we must have noticed in our anatomy, dissections and all of those things, that the superior oblique muscle and the inferior oblique muscle, when we open up and then see, they go straight like this. There's a trochlea, they take a turn and they come back in this oblique fashion. However, they're coming back in that oblique fashion. That obliquity was determined by the oblique orientation of the posterior sensor. Because the sensor and that motor had to be in the single plane, same plane, parallel, but same parallel plane, so that the intervening calculations could be minimized. Is that okay? So what does that bring to? That brings us to a one-to-one correlation between a semicircular canal and an extraocular muscle. And we know each extraocular muscle is a unique, a different kind of action, primary action. Which means you can see the action that is happening in the muscle, eye muscle, and based on that deduce which semicircular canal is producing that particular action. And this is the key concept in localizing which canal is affected in which kind of BPP. This is the key concept. So which brings us to something very unique, and that one is you decide which canal is involved, not based on मैंने डिक्सल्पाइट किया, मैंने ये किया, मैंने वो किया, all these tests. डिक्सल्पाइट तो posterior canal का है, तो डिक्सल्पाइट में जो भी मिस्टेक बसाता है वो posterior canal का ही होना है, ऐसा नहीं है. What mistake must you give? That is produced by which extraocular muscle, and that extraocular muscle can be moved by only that semicircular canal. Now you say that is the particular semicircular canal producing this particular mistake. This is part one. Presence of nystagmus on head rotation itself does not say it is pathological. This is very, very important point. Because today when you rotated, you got a nystagmus. Did you all get a nystagmus? If you all lie down and rotate to the right also, you will get a nystagmus. If you lie down and rotate to the left also, you will get a nystagmus. This is an important point. Why I spent some extra years in I am an instrument maker, okay? To add a head animation on top of an eye video is to solve my own problem, because I used to get videos from a lot of people. I made a device only with the eye movement, which you saw with Prateek. So what used to happen is, I was finding it very hard to determine ये nystagmus जो मैं देख रहा हूँ वो physiological है जो आई हेड मूवमेंट के साथ साथ हो रहा है या आई हेड मूवमेंट स्टॉप होने के बाद स्टार्ट हो रहा है. That was very important to tell pathology and physiology, which is the cause of confusion and misdiagnosis. Lot of time looking at remote videos. So I added a head for that particular purpose. This is very important to know when the nystagmus is happening. Now we know there is a nystagmus physiologically that can happen when you are moving in any particular plane. Now a BPPV CAT. What is benign paroxysmal positional vertigo? Now, most important thing in the semicircular canal, the beauty of the construction of the semicircular canal is a tubular construction. Okay? The beauty of the construction of the semicircular canal is it has a tubular construction. It's a pipe-like construction. And what is that pipe-like construction does is very nice. Okay, I will come to that now. I will show that. So what a pipe-like, if you take, if you are sitting in a bus, okay, if you are sitting in a bus, and if the bus suddenly starts going in one direction, the bus suddenly starts going in one direction, suddenly starts going forward, what will happen to you? You will fall backwards. Is that correct? Sudden acceleration. Sudden deceleration, you will go like this. If the bus swerves to one side, you will fall to the other side. If the bus swerves to other side, you will fall to this side. So there is no way in which you are going to restrict your movement. You can fall to any side based on how your container is moving. Is that okay? Now, if your body, as long as your body is straight, if you take the bus is not moving or not accelerating, decelerating, swerving right, swerving left, and if somebody tells I will put one sensor on your body, each and every time your body is just activated or turns or leans in whichever direction, that is taken as a signal that the bus has moved right, left, front or back. Is that okay? That is the kind of thing that is called the hair cell. That is the hair cell, which is a mechanoreceptor, which means if there is a movement, it will detect that movement. Okay, if there is a different movement, that is there. But the unfortunate thing about in a bus is, it can tell that some kind of accelerations happen forward, backward, rightward, leftward, but it cannot tell ki forward you are, backward you are, rightward you are, leftward you are. It is not going to tell. Is that okay? Now, instead of that, if you take that particular sensor and put it in a tube, it has a beautiful property. That, if you put it in a tube, when the water in the tube moves, if that canal, if that particular thing is going to get activated or get deformed. Let us see how a tube behaves. This is a tube, a canal tube. If you take this tube and accelerate it forwards, what will happen? The molecules on this side will try to push like this. Is that correct? The molecules on this side will try to push like this. Means whatever is here hits on the wall, it fails. Whatever is here, it comes like this. Whatever is here is redirected. The forces are redirected. They come here. They come here. What is happening? It's a complete tube construction. So when you are pushing it like this, all of these forces on this side, the forces on this side, they meet here. They cancel. Is that okay? Basically, just by placing that particular sensor in a tube, you make it immune to the influences of linear motion or linear acceleration forces. What is that linear acceleration force which is always present on us?
Gravity.
Gravity. So it is done, rendered immune to linear acceleration. Just by a tubular construction. This is the beauty of why the semicircular canal is a semicircular canal. It is not a semicircular, it's a complete circle. For all practical purposes, it's a misnomer semicircular. Everybody who has done dissections of temporal bone know that it's much more than a semicircle, it's much bigger. Whereas if you place the same tube and rotate the head, here what will happen is, if the rotation is in one direction, the movement is in the movement on one side is like this, the movement on the other side is like this, there is a force multiplication. For linear movements, there is a force cancellation. For this one, there is a force multiplication. Clear so far? So, a normal semicircular canal never should respond to gravity. A normal semicircular canal should respond to rotations. This is normal. What happens in abnormal is this. So now we can replace the entire mass on either side with point mass. This is easy in physics to make it. A point does not mean point. So easy for calculation. So in the first situation of linear acceleration, this mass and this mass is equal. Force is equal to mass into acceleration. The entire head is going through the same amount of acceleration force. This side mass and this side mass is equal. So this side is F1, this side is F2. Mass is same. So the force will be F1 should be equal to F2. Is that correct? Hello?
Yes, yes.
Jada physics to nahi hua. It's okay, no? This much is okay. And it is good to get reminded about 8th standard, 9th standard, 10th standard, sweet good days which we cannot go back to. But okay. Now, see this. If you take a calcium carbonate crystal and place it in the semicircular canal, the canal was filled with water. On one side, if you place the crystal now has the same mass as water, it has little higher mass as water. It will have a higher mass than water. Now what we'll do is, when you apply the same linear acceleration force which can be gravity, this F1, this M1 has bigger mass, this F2 has smaller mass. Therefore, in the final fight between these two columns, the one with the bigger mass will win and will end up deflecting the fluids in the other direction. Is that correct? Which means adding any foreign particle of a heavier mass will render that semicircular canal suddenly responsive to gravity. So what is benign paroxysmal positional vertigo? Benign paroxysmal positional vertigo is a semicircular canal rendered inappropriately sensitive to gravity. Is a semicircular canal which is rendered inappropriately sensitive to gravity. How long will the sensitivity to gravity remain? The sensitivity to gravity will remain only till this particular thing becomes equal part of this column and this column. That is when it finally, the force will ensure that it starts moving, and it will come and occupy this place. Then it is equal part, and that time there is no more problem. Is that okay? How long it takes? It takes 30 seconds, it takes 60 seconds, it takes. After that it stops. Is that okay? That is why benign paroxysmal positional vertigo is inappropriate sensitivity to gravity, but then it comes with its own expiration time. After some time it's all gone. Clear so far? Its own expiration time, and after some time this is.
So, but why ascendo and crescendo pattern?
Because it starts building up. It starts and then it starts building up. Acceleration keeps building up. So if you drop something from the top, under the force of gravity, it starts off with a low velocity, it increases the velocity. By the time it goes down, and then again there's a curvature, and then it starts coming to a stop. Okay. So there is a crescendo and a decrescendo. Okay. So there is like a parachuting effect. First, he start building up and then starts going down. Okay. So this is what happens in benign paroxysmal positional voting. Two important concepts. First is what is BPPV? It is a semicircular canal rendered inappropriately sensitive to gravity. Second important concept is each semicircular canal is attached to, is neurally linked to one extraocular muscle in each eye. Okay, for excitation, one extraocular muscle in each eye for inhibition, which will tell exactly this is the plane of movement only. It will not happen in any other plane. That movement belongs to that one. Clear so far? Okay. Now, why should this cause symptoms? Once it is okay that it becomes rendered sensitive to gravity. Why should it cause problems? It should cause problems. It causes problems. The reason is semicircular canal is not meant to be a gravity detector. In fact, it is meant not to be a gravity detector. And semicircular canals are reasonably well formed by 5th month of intrauterine life. From that particular moment on time onwards, whenever a fluid moves in the semicircular canal, it has only been brought about by a rotation and not by any linear force. It has always been brought about by a rotation. It has always never responded to linear acceleration force, including to gravity. Therefore, the neural connections of the semicircular canal go to extraocular muscles to make that compensatory eye movement which all you saw to stabilize gaze. Is that clear? Which all of you saw to stabilize gaze. That is the number one thing that you saw. The next thing that they do not, and they also go the neural network to the perceptrons responsible to perceive that particular movement. So the perceptron for perceiving that rotation and the eye muscles for making that movement. This is what has been happening. Okay. Now, suddenly making the change and suddenly making it responsive to gravity does not instantaneously change the neural connections. It cannot change the neural connection. Whenever there is a semicircular canal activation, the perception is of rotation and the eyes move. Now coming to again our initial experiment. The initial experiment was that we induced a nystagmus in each of us and we got a stable vision. Is that right? Why did you get a stable vision when you induced nystagmus? Because you were also actually rotating. Is that right? Eye movement in motion causes stable vision. Now this particular individual in semicircular canal, he changes the position, he comes to a stop. After he has come to stop, he is no longer moving the head. But when he has come to a stop, the eye starts moving. In the absence of a real movement, eye movement is going to stabilize vision or worsen vision. It's going to worsen vision. Is that correct? To compensate for your movement, eyes have to move. But when you are not moving, movement of eyes is going to make your vision worsen. This is what is happening. So the person tells, I feel blurring of vision. He says that I perceive that I am rotating. So he sees a vision that is getting blurred or a vision that is moving and he sees that things are going. Is that okay? This is what happens in semicircular, in benign paroxysmal positional vertigo. Now when it comes to benign paroxysmal positional vertigo, what is it a disease of? What is there in the semicircular canal? What came into the semicircular canal? A notoli, a calcium carbonate crystal. This calcium carbonate crystal, where does it actually belong to? It's not a totally foreign material. It is not a totally foreign material. It's a foreign material to the semicircular canal. It is not a foreign material to the ear acid. It is there somewhere in the ear. Where is it there? It is there in the utricle and it is there in the saccule. They are normal constituents of utricle and saccule. Why are they normal constituents of utricle and saccule? They are normal constituents of utricle and saccule because utricle and saccule are gravity detectors. And how do you detect gravity? How do you determine what is a straight line, what is a vertical line in day-to-day life? A mason who is constructing this building, what does he use? He uses something called a plumb bob or a plumb line. A plumb line or a plumb bob is something that is heavy, tied on a string, which will hold the string always vertically oriented. Therefore, based on that, he knows that this is a straight line. This is vertically being, this wall is being vertical. Similar mechanism in our body is the stone in the ear. He uses a stone or an iron, which can be considered as a stone. We also use a stone that is called calcium carbonate crystal. We chose to place that stone in the ear, otto. Stone is lith, that is why it is called otolith organ. Okay, that is why it is called otolith organ, which is a gravity detector. Now that particular, and then that leans or leans whichever direction to tilt, and then you come to it. But the secular otoconia, if they become loose, no, they cannot enter the semicircular canal. They cause other symptoms, but they cannot enter the semicircular. Utricular otoconia, when they become loose, they don't stay in the utricular cavity. They go to other things that are connected to the utricle. The semicircular canals, all the three semicircular canals are connected to the utricle. Is that okay? They are connected to the utricle. So therefore they enter, they render the semicircular canal responsive to gravity, and that responsiveness to gravity is not the natural job of the semicircular canal. It causes the perception whenever they are activated, perception of rotation, because semicircular canals are neurally connected to rotation perceiving perceptrons. Semicircular canals are connected to extraocular muscles to move whenever the semicircular canals are active. So you see a nystagmus, you see a perception. This is benign paroxysmal positional vertigo for all practical purposes. But where did it come from? The debris come from? From the utricle. Will a normal utricle shed a shed the otolith? It will not. A normal healthy utricle will not shed its otoconia. If a utricle has shed its otoconia, that means utricle is itself diseased, which brings it to our point. BPPV is primarily a utricular disease. Semicircular canal is an internal auto-analyzer which is checking and telling a utricle sahi nahi hai. Okay, utricle is primarily a, is that okay? This is the, which means you will expect that BPPV will not just have positional vertigo, but will have some other symptoms related to utricle also, some kind of walking instability, these kind of things. Other also, there are some people not sure-footed. Sometimes they have a first fall and then next day they will have a BPPV, like that. So there is head heaviness. These kind of feelings is what is seen, including in certain untreated BPPV patients. Of course, you will see. It is not just positional vertigo, there are other things also. So you need to make sure that. So that is why it is important to note what was the event that led to the utricle to shed it. It could be a migrainous vasospasm. Okay, it could be a day of dehydration. So like that, there are other preceding events which are predisposed to this particular thing. It could be a person having gone through a marathon running, which led to acidosis, and the acidosis made the calcium carbonate to cleave and then get released. So many mechanisms can be happening. Second thing is, utricle itself may not be so healthy. Vegetarian diet. Okay, utricle is not that healthy. Deficiencies of vitamin D. Deficiencies of, okay, for all, I am not scolding any vegetarian here, because for all practical purposes, all Indians are vegetarian. Because only when you go to Europe, you will know what a true non-vegetarian is. Oh, breakfast, lunch, dinner, everything. For them, vegetarian is vegetable. When the first time I went to Dubai, I wanted to have some vegetarian, but now it has changed. Dubai has everything Indian now. But the first time, long ago, when I went to a hotel, I want vegetarian, they gave me some vegetables. Okay, this is what is vegetarian. My God. So now we get more Indian food than Indian. Okay, there. So like this is, but there it is every day. Here, Sunday mein khata hu, non-vegetarian. Only afternoon, Sunday we eat and we call ourselves non-vegetarian. Monday we don't eat, Tuesday we don't eat, Thursday we don't eat. Correct? No? Like that. So this is a predisposing factor. Why I am coming to that is, it is very essential that we treat BPPV not just with the positional maneuver, we also should treat the underlying utricular disease. And the simplest thing that we should start off is, if the person is a migrainer, to take care of the migraine of the BPPV patient. If the person you think is, we should at least start amino acids, which I have made a strong practice of. Okay, migraine, replenishment of amino acids is very, very important. Just see where the BPPV is more common. Okay, just by seeing like who sees the maximum number of BPPV patients. Dr. Ajay works in Udaipur. What is the diet there in Udaipur? Definitely, I'm 100% sure we can see number of, if you see the incidence in population in Lucknow where they use all the beautiful non-vegetarian diet versus Udaipur where the diet is fully vegetarian. If you see, then we will know how much of protein deficiency would be the real cause for this amount of increased BPP. At least my perception is BPP is more common there than here. Okay, but because we see the number of different types of BPP cases that Dr. Ajay posts versus what we see. Okay, which definitely tells that indication is more, or he is attracting from all over the country. That we don't know. Okay, so that is there. So to understand that it is primarily a utricular disease is very, very important. So it means that it is right to give certain drugs in these people aimed at improving the health of the uterus. Is that okay? Now coming to some of you people are said that some of you are doing play Dixalpite every day. Now I want to go to some problems that we are facing. The first problem that a person who is actually doing Dixalpite test is facing, we will give a demonstration of all those things, is that, sir, history is like BPPV. लेकिन Dixalpite test में कुछ नहीं मिल रहा है. Of the people who are doing this, raise your hand. Okay, कुछ नहीं मिल रहा है. Okay. Now, if the history is BPPV, you can keep a dictum that it is likely BPPV. अगर history BPPV का है, then think that it is mostly BPPV. Then what? Why did you not get it? Possibly, you did not test for all the canals. Which means, in addition to doing Dixalpite test, you should start doing the Macular-Pegnini test also. Second thing is, for some reason, at home every time they change the position they are getting. In the clinic for the first time they are not getting. So you do minimum 3 times Dixalpite test before telling it is negative. Second thing. Third thing is, it is there, but your test was not optimal to detect that type of BPPV. If it is in the posterior canal, if it is a cupulolithiasis, it will not show up all the time in the Dixalpite test. It will only show up in what is called a half-alpine test, in which once you take the patient down, you have to lift the hand up also and wait and see. This is called a half-alpine test. Is that okay? That is the half-alpine test, which we should see. All these things, where to get, I will show you the resources for all of this. So you need to do the half-alpine test. Next thing, Dr. Pradeep is going to give you examples of all of these things in his presentation. The next thing in BPPV that we need to be sure. Yes?
Sir, sorry. So the migraine patient also have sometimes the typical complaints of.
It can be pure migraine, positional migraine vertiginous crisis. It can be migraine plus BPPV concomitant. Both are possible.
So sometimes I've seen one patient specifically that you said that when the patient asked to lie down and the patient doesn't have any symptoms. At home he is always having.
Yes.
So at that time what I said to the patient that lie down in the bed at a couch, how you lie down in the home. And that triggered the posterior canal BPPV. He said whenever I looked at the time on the back side in the bed only, then it happens. But when I did the Dixalpite, it was not coming. You need to do where the clock is there and you just do that, simulate that motion. And when he did that motion, there was a proper posterior canal and they did the maneuver and he was fine. So this is one of the things which I want to
show.
So
that is the last step I was coming to. Okay. So you're all reading my mind and telling me first on this. Okay. So that is beautiful. Now why that makes sense is, previously we had an unwritten understanding inside which is not correct, that this maneuver is for this canal. Now with all the discussion that we did, we know maneuver and canal need not be related. As long as you see the nystagmus देख के कौन सा canal है हम पता कर सकते. So let the patient generating whatever. So what sir told, you can use that. Finally, if nothing is showing, you ask the person, आप दिखाओ. मैं क्या goggle पहनाऊंगा, आप दिखाओ. I'll put a goggle. Now you show me how it is. Then let him turn the way he is doing, because the most important thing is patient never came to you telling, sir मैं जब घर पे डिक्साल पे करता हूँ तब चक्कर आता है. तो ऐसा तो कोई पेशेंट नहीं होते. पेशेंट टेल्स मैं जब घर पे सोता हूँ, लेटता हूँ, राइट लेफ्ट, then that is when the patient tells. Is that okay? That is why the patient tells. Okay, is that fine? So when the patient is telling like that, so that is how you are supposed to ask also. So finally it is like, maybe eventually in few days to come, our understanding is so strong that you not even, you skip all these things, put the goggle and tell the patient, सब करके दिखाओ, बाद में हम देखेंगे test करेंगे. Maybe that will be the first step rather than being the last step. Okay. So coming to the next thing that happens in the people who are doing Dixalpec test is, you will see, sir, Dixalpec जब किया कुछ problem नहीं हुआ, but getting up is the problem. When getting up is the problem. If the getting up is the problem, then the problem is in a location called short arm posterior canal, which Dr. Pradeep is going to elaborate on. Okay, he is going to elaborate on this particular condition called short arm posterior canal. Is that fine? Short arm posterior canal. This is where you are going to get the problem. This is in fact more common. Nowadays we are seeing this is turning out to be the commonest form. Okay?
This is the commonest I'm finding.
I am also. Now, we were not looking for that before. We were dismissing all this as migraine before. In fact, if you see some of the recordings of the YouTube where people have asked this question to me, I have answered they are all migraine. Okay, this is because of Ajay Vatt's work, Dr. Ajay Vatt's work, that we have started recognizing this one. There is another condition where person tells, he came walking, sir, I used to get only positional vertigo. You did the maneuver. After doing the maneuver, patient tells, sir, पहले तो सिर्फ पोजीशन बदलने से आता था, अभी तो आई एम नॉट इवन एबल टू टेक अ स्टेप. आई एम इवन वर्सन पोस्ट. who all have seen this? एप्ली मनोवर के बाद.
It converts into horizontal.
Yes, there are two possibilities. Two possibilities here. Both documented in literature, both documented by my friends. Either it has converted to horizontal canal or it has converted to short. So if the person is worse off, don't listen to all these people coming from abroad, pharma sponsorship से आके 3 महीना वर्किंग बता के जाते. Post BPPV dizziness. Okay, beggars know nothing. Okay, some of these big names know nothing. Okay, I will tell you. Okay, 3 महीना BPPV को ये दो all these things, and pharma people love them. Okay, this is most of the time a horizontal conversion or a short-term conversion. Deal with it then and there. What? How to deal with? Check for horizontal canal or horizontal canal का maneuver जो है वो करें. Check for short-term posterior canal and then do a bow and yaw maneuver. There only 10 minutes. In the next 1 minute, your problem is solved. In the next 1 minute, the problem is solved. It is like, for me, it is simple. I take the example of bronchoscopy. I start taking from the right main bronchus, I start pulling. It comes and sits just under the glottis. Subglottic level, it slips. What is the problem for it? Is there an equivalent for 3 months of, in bronchoscopy, if there was an equivalent of 3 months of beta histine, then it would be 3 months of steroid when the foreign body come out. Then you have to hold up, go, pull it out and come out. Is that correct? Now if it has gone into another canal, you can't camouflage that by 3 months of drugs. Deal with that canal, finish it off. That's it. Just deal with that canal, finish it off, and you are cool, you are happy. Then and there the problem is solved. Okay, so these are some of the difficult situations. Now the question here now is, we are taking it because, see, why I went like this was, okay, there is a reason why I went like this was, already people are doing Dixalpec, so I thought I'll just go to next level. Is that okay? That was okay, right? But
so
we are all.
A lot of junior colleagues also.
Also there. So I know that also. So what I want is, I have a QR code for junior. Because junior colleagues are also tech savvy. Scan that QR code. एक YouTube का चैनल खुलेगा. 5 सेकंड के अंदर अंदर आपने सब्सक्राइब बटन पे क्लिक किया, 20 साल तक गुड लक आपको. This is truth. Because you treat BPPV well. Subscribe किया ना? Bell. कमेंट भी कर सकते, शेयर भी कर सकते, all of those things. This is the place where you have two playlists. One playlist is called therapeutic, diagnostic maneuvers. Another playlist is called therapeutic maneuvers. So in the diagnostic maneuvers playlist, see them. You have come to ChakkarCon. Tomorrow morning, get a junior colleague, offer him a surgical chance, ask him to. कल मैं काउंसिल करने को दूंगा, टपटम करने को दूंगा. एंटीरियर एडमिट तक आप ही को है चांस. फर्स्ट ईयर. आज become a subject for my practice. ठीक है, and practice all of these things because these are not big. These are not big. Okay, is that fine? But still, I want to demonstrate. Prateek, we can demonstrate right now. Okay.
So hands-on है वैसे.
Hey, so hands-on है. So no need. So we will show you in the hands-on. We will show you instrumentation also in the hands-on. Is that okay? Superb. But stay on. Okay. Now you know. It was 5 o'clock OPD. Today is not OPD also. Sunday. Lucknow में OPD चलते हैं Sunday. चलाते. Today you cancel it. Okay. Now only बता दो. Call करके. मैं नहीं आ रहा हूँ शाम 5 to 5 o'clock. Okay. Send that message. Fine. So we are going to show the hands-on all the maneuvers. We are going to make you do the hands-on maneuvers. So this is it. Finally, in the BPPV, you need to clear that debris. Okay, you need to clear that debris also. How to identify which canal is affected? How to identify which canal is affected? Odd locations, how to identify? All of them. The pathophysiological understanding, I think all of you have. Is that correct? So what was the problem? Problem is in the utricle. How did you come to know the problem is in the utricle? Because the person developed a BPPV. What is the cure for the BPPV? Remove that debris, put it back into the utricle. How do you do that? We need to do a series of maneuvers. How to do that maneuvers? Evening hands-on. Is that okay? That is there. How to do those particular maneuvers? Is there? That is what you do. How to identify which canal debris is? Dr. Pradeep. He is going to show the next present. Correct me, your turn. He is doing that. So how to identify right, left, whatever these things. What is the basis of that particular identification? It is the neural connection, one-to-one correlation between semicircular canal and particular muscle, which we all know. Clear so far? This is how we are going to do. Odd situations, only on getting up, short arm. Half halbpipe test में ही आता है. And then it goes on. It is cupulolithiasis. Cupulolithiasis will not show up in the actual full Dixal test. Only on the half halbpipe test, cupulolithiasis shows up. Therefore, please make sure that all your cases, you don't complete a Dixalpipe test without doing a half alpine step. Okay? So, if the Dixalpipe head goes down, the half alpine head comes down. And then hold it in 30 seconds. If in the half alpine case it comes, it can be cupulolithiasis or it can be short arm. In cupulolithiasis, this thing is going on and on. In short arm, it comes very fast and then stops off. Is that okay? This is how you want to differentiate between short arm and cupulolithiasis. So, check for these things. What is conversion? If a person is worse off on standing, he does not deserve 3 months of beta stay. He deserves again checking for conversion to other canals, dealing with it then and there. Is that okay? That is what we are supposed to be doing. Okay.
Could you please repeat the name of the test that you said after Dix Alpine? Not half alpine, but another test to it.
The treatment for short arm is Bowendia. Bowendia, prone Bowendia. We will show that. Okay. Prone pitch and
Sir, I had a patient with Apple's maneuver, he did not respond. Posterior canal PPG. But when I did Semont, it responded. What was the cause?
So the reason is, one is, for some reason, even I see that Semont maneuver has a little marginally better success rate. Okay. Second thing is, maybe even the second Ipli would have responded. The reason is that it gets activated. That the debris does not move in the first time, maybe it moves in the second time or the third time. So that is why we don't do one day maneuver and leave. My regimen is, after doing the maneuver here, I tell the patient to keep doing the maneuver for next 1 week to 10 days at home. I teach them accept. Okay. Even small bits of debris is there, left out, that also. Yes.
Just to like to counter.
You can take a mic, sir.
Against the regular principle, it's not about the autoconia that is problematic. From utricle, if few autoconia fall down from the utricular macula, it's not problematic. It's the autoconial protein or the autoconial holding membrane that comes like a gel, which holds few autoconia. If that jelly membrane is coming and entering the semicircular canal, that is the problematic thing. If single autoconia is there, it can move along the gravity. But a mesh of protein with autoconia will be moving in the canal, but somewhere, like all of us are ENT surgeons, all the mastoids are not same. You find a corner septum very laterally, you find in few cases you find corner septum more medially. In the same way, the semicircular canal or its angulation is not same in all the patients. So when this jelly-like material along with the autoconia is moving in the semicircular canal, somewhere it can get anchored. Even with gravity, it can get anchored. So when you do a Semont maneuver, which is a laboratory maneuver, which gives a lot of thrust, so it can get detached. So that's why Semont maneuver has a better prognosis, or better value, better result than Epleason. So please think that it is a matrix of protein with few autoconia. Don't think it's only autoconia. Only autoconia is nonsense. Autoconia is always sticky, it's always embedded with gel. So that's why do autoconial clumping happens. Autoconia will have a jelly-like substance around it, so that it attracts the other substance. So that's why unless you form a clump, the gravity does not have impact on that. So to form a clump or to do anything, your jelly-like matrix is the.
So to extend that, because both of you elevated the discussion to next level. So there is another thing. There are some experimental studies that were done, which was presented to us by Thomas Richard Witten. If you don't know who is Thomas Richard Witten, TRV, there is a particular type of chair that is there present, which costs about 1 crore or something like that. 1.5 crores, that chair, one chair. Okay, like it competes with CT scan machines in terms of cost and all. Okay, it's just a chair, okay, but it's a beautiful chair. So he is the maker of that particular chair, and then he showed a presentation where natural flow, rate of flow, can be few seconds, as we see in the classic BPPVs, to few hours, 7 hours, 8 hours also. In some people, if the debris moves so slowly, these are the people who present with totally vague symptoms. Vague symptoms. So then they are going to the extent of suggesting that some of the so-called triple PDs, which are considered as functional disorders, can be the small weight debris or too sticky debris, which are taking a long time to settle, like ESR. There is somebody in whom it settles fast and other people. That is why there is a particular maneuver which we are going to show in the evening. That maneuver is called a little bit different from Shavasana, means taking rest. That is prolonged positioning. You just take rest in one particular position because you now know the which side is the thing. All night you sleep in that direction, it will come slowly and settle down. Sometimes that can be like a cyclical maneuver. 1 day right, 1 day back, 1 day left. Like that if you do, it will settle down. Okay, so this is also, so that this is prolonged. Yeah. So Prateek is telling everybody is hungry. Okay, is that fine? So what we will do is, we'll break for lunch, we'll come back after lunch, and then we will continue the discussion. Okay. In between something, that schedule is not being followed, I think. No? So that is okay. Learning is more important. Yes. Is that fine? So after this, Pradeep will come and Pradeep will take the tips and tricks of the PPT. Clear? Let us break for lunch. Thank you all. Thank you so much.